Hello, everybody. Let me just get this started. Okay. Welcome to the Bone Builders Kickoff on demand. I'm going to cover a lot of what we'll be discussing over the next year, very superficially, but I don't want you to sweat the details because we'll go over it in much more depth at all of our sessions. But this is just to give you an idea of what we'll be doing. So, as I'm sure all of you watching this know, I've been doing group visits now for a while. And I did them first for diabetics and pre-diabetics for helping them if they wanted to lose weight. And that was so much fun that then I was like, well, what's something else I could do? And I had just started reading two books by this guy, Dr. Keith McCormick, that I'll talk about in a second. And uh, and I kind of was on the weight loss journey with the weight loss group. Then, because of losing so much weight, I went from osteopenia to osteoporosis. So now I'm on the osteoporosis journey. So I thought, well, let's do that as a group. Um, we're also going to be launching a menopause group and a reversing and preventing Alzheimer's group. So that the Alzheimer's group is definitely one that hits close to home because my husband's family has a lot of Alzheimer's. So we're putting it into practice for both of us to try to prevent us getting it. My family has dementia too, not necessarily Alzheimer's. But so all these groups I'm also learning for myself as well as all of you. But what I really like about the group visits is that I can teach you a lot more about a subject. And it turns out that osteoporosis was much more complicated than any of us realized when we started this group a year ago. Uh, it's you always learn something much better when you're trying to teach it to somebody else. So it was uh, we had a group start out. I think we had 17 to start, or do we have 18? And we had one drop out near the beginning and one who dropped out near the end. So I think 16 of them did the whole year. Um, anyway, I think that they learned a lot. They learned it from each other. They did also function somewhat as a support group. They can hold each other accountable. It's just another model for providing care, and it's turned out to be a lot of fun. Uh, and I have to remember when I send out this invitation, I will be attaching um, a form that you'll fill out that if you want to attend, to commit to attending as much as possible and to commit to the privacy of the group. Everything we discuss in the group has to stay in the group. But some of what really led to this group was also we were having Prolia problems. I had had a certain number of people on Prolia. I don't know how many. It's not like more than 10, but it's more than 5. And in the last couple of years, we discovered some unexpected issues that we thought only happened with bisphosphonates. Prolia wasn't supposed to have dental issues or osteonecrosis of the jaw, but it turns out it can. And they also figured out rather recently that you can't just stop it, especially if you've been on it especially if you've had any more than 2 doses. Uh, but especially people who've had more than 3 and have been on it for years. If you just stop it and do nothing in 6 to 9 months, a huge percentage will have rebound vertebral fractures. If and they estimate it'll happen to 73 to 90% of them. Now, I had 3 people who were going off Prolia, and I couldn't find the answer for how to stop that from anyone at first, and it was because they just didn't have a protocol yet. But then I found Dr. Keith McCormick on a YouTube video talking about how he would handle it, and it made a lot of sense. And he had also just written a book, and his book did have how to go on off Prolia in it, so he had figured it out. He was a chiropractor. I thought he was from Canada. I don't know where I got the Canada idea, um, but he's not. He's in the United States, and he himself had osteoporosis, and he was an endurance athlete. Turns out, and I wish I'd known this before I had been an endurance athlete. Athletics aren't good for bones. Now that I know it, it doesn't seem that surprising. Because endurance athletes, that's like doing things for a very long time. Endurance athletes, my husband's done 100-mile races. I've never done that. I just did an Ironman. And I've done some marathons, but it turns out that type of long distance running isn't conducive to holding on to your bone either. So I thought I was being ultra fit. I was not, but live and learn. So I wouldn't do any more of those long races. So Dr. McCormick, who'd been doing them since he was in his teens or 20s, started fracturing in his 40s. And you can imagine how panicked he was. Here he is, a chiropractor, and chiropractors, their main thing they work on is bones and musculoskeletal tissue, and his is melting. So he went and saw 10 endocrinologists before he found one that would give him a plan that would turn his bones around and not have to stay on medication forever. And so that's why he knows how to do it. So that's why his book was so helpful for figuring this out. I've always been an advocate of the Strong Women, Strong Bones series, and she has all kinds of strong people beat arthritis, strong women stay slim. But it's Miriam Nelson. She did all this research on how weightlifting mixed with aerobics was so important for so many things. And so she has an osteoporosis workout, but it came out in 1998. And I also follow this Margaret Martin, a physical therapist on YouTube. And I think a lot of her advice for osteoporosis exercise is way more up to date. So, for example, there are some seated exercises in Strong Women, Strong Bones, and Margaret Martin tells us that we should do all those standing. That when you're seated, it puts more pressure on your vertebra. So, especially if your spine is osteoporosis range, you want to do all the exercises that you can standing. And we'll discuss that further when we get to that section. So today's talk is about looking at the topics we plan to cover, a little bit about bone biology and why we lose it, evaluating how we'll evaluate our bone loss and fracture risk. Healthy soft tissue can mean healthy bones, so we're going to look at signs and symptoms of nutrient deficiencies. Chronic inflammation is the enemy of bones, what we can do about that. Dietary approach to reducing chronic inflammation. We also have low-dose immunotherapy to reduce chronic inflammation that I talk about. Vitamin D3 and K2 is a yes. Calcium we thought was a no for a while. It actually should not be avoided, especially if you have osteopenia or osteoporosis, but it should be limited. You should be getting a max of 600 to 700 milligrams daily from supplements and fortified foods. Fortified foods basically add the supplement in for you, so they have to count as a supplement. So if you drink calcium fortified orange juice, for example, that counts as part of your calcium supplementation. And then even Dr. McCormick, a chiropractor, had to take medication, but he has figured out how to do it in a way that you won't be on it for more than a few years, and then you can just every 5 years or so do a dose of Reclast if you need it to maintain it, but you don't have to be on it forever. Most of my participants in this class we found needed more than just 100 or 180 micrograms of the vitamin K2 as well. So we now carry something called K-Rite that has less vitamin D because we actually want vitamin D between 35 and 60 in people who are trying to preserve bone. If we have to decide between preventing GI cancer and bone loss, we'll figure that out at the time because if you have a first degree relative, if you've had a first degree relative with some type of GI cancer, then your recommended vitamin D level is 75. But at that level, it will mess up your bones. So um, that was one of the biggest eye openers of this last year's group. So these are the topics we're going to cover. Originally, I had 12 topics, but the last topic was the 12th one was controversies around hormones, which I ended up covering when I went over hormones, and controversies around strontium, which I covered under minerals and supplements for better bones, because strontium's usually sold as a supplement. So we didn't end up needing the 12th session. And that's okay. So we have 11 sessions. And these are them. We're going to talk a little bit about signs and symptoms today of nutrient deficiency so that you're prepared for the first one. And the second one, we look at everyone's bone densities. And that was another huge shock. There were so many errors, and I'll talk about that in a little bit. We talk about all the lab testing, which can be very extensive. We've designed a workout that you could do 15 minutes a day, 6 days a week, would get you a nice 60 minutes of weightlifting for those who are maintaining. And if you do 90 minutes, you'll improve a lot. Talk about an optimal diet for bone health, especially pertaining to gluten. Minerals and supplements for better bones is where we'll talk about all the minerals, including a little bit about calcium, but calcium gets its own session a little later on. Then we're going to talk all about medications. We're going to learn about the parathyroid system, which I admittedly didn't know much about and have discovered is a factor in probably 2/3 of the patients who were in our cohort. So that was a shock. That was one of the biggest eye openers from this book. Dr. McCormick said that even though the range of calcium normal goes from 8.6 to 10.3, if your parathyroid is good, it should always stay between 9 and 9.9. So anyone who has some readings outside of that should have their parathyroid looked at. And so I've been doing that both in all the patients in this osteoporosis, osteopenia category, but even all my regular patients, if I see they have a bunch of calcium readings. And I have found all kinds of parathyroid issues that we had no clue about. Parathyroid is, they're like 4 little grains of rice on top of the thyroid. That's why it's called parathyroid. And they are separate from the thyroid. They don't do the same thing. And although they have some thyroid we talk about thyroid hormone, all the time, but thyroid gland also makes a hormone called calcitonin that affects calcium. So they are both involved in calcium metabolism. Then we're going to go over all the interesting information about hormones that there I'm speaking mainly to women about menopausal hormone therapy. And in the future, if we ever allow men to join us, then we would talk about testosterone for them, although it's estrogen actually that matters for their bones as well. Then we talked about using bone turnover markers to monitor therapy, to know when you need to go on a drug holiday or go off of Prolia, and how to go off of Prolia. And then the last one was more ways to reduce our risk, getting off medications that increase your risk of osteoporosis that are used typically. The most common ones are proton pump inhibitors for GERD, antidepressants, and please no one ever stop your antidepressant without talking to me first. And allergies and autoimmune disease a lot of those people who have those issues get treated an awful lot with steroids, and steroids are the enemy of bone. And we can treat those with low dose immunotherapy and get rid of them. So it's definitely worth considering. Yeah, I mean, get rid of them. It's amazing. So now we're going to do some bone biology. Our bone is mainly made up of two kinds of bone. There's compact and cancellous. Compact bone is the hard outer cortex or exterior of the bone. It's more what you imagine bones to be like, like if you're having a ribeye steak, that really hard bone. That would be a compact bone. But if you think about like a bone you might get for your dog, a beef bone, that it would be the outer part, but then that inner part that has this honeycomb-like structure, that's the cancellous bone, and that's where our bone marrow is located. And all those little divides between the cells that you see are the trabecula. It's a lattice of 3D structural beams that is very much like a honeycomb, and that's what makes it so that our bones can stay light and be tough but feather light for, I mean, for what they do. Um, Now some there's three kinds of cells that have a lot to do with bone biology. They're osteoclasts, osteoblasts, and osteocytes. Clasts chew, blasts build. Okay, so that's how you can remember those. I would say C for chew, but osteocytes also has a C, but it's the one that sounds like the other one. So clasts and blasts. Okay, this is how I have remembered it forever. So the osteoclasts are like Pac-Man. They come along and they chew up bone. They chew it up with acid and ingest all the debris. They're very big cells and they're highly mobile. They are attracted by signals to the areas of bone that need attention. Precursor cells are halfway between a stem cell and a specialized cell and ready for action. When they get the right signal, they fuse together to form these osteoclasts, and they do that after receiving the rank L signal as a signal from the osteoblasts. And it takes both of these to remodel bone and is what keeps our bone remodeling in what's called a coupled process. So here's the osteoblast. Remember, blast build. They pre-osteoclasts, those are the precursor cells to osteoblasts, brush against the precursor cells to osteoclasts and cause them to release rank L, and rank L then helps that precursor cell become an osteoclast. Osteocytes supervise the whole process. They're the managers. And they supervise the complicated process. They're embedded in the bone matrix and they extend an arm like a flag, and that's what calls over the osteoclasts. So the osteoclasts come first to the area that they're saying, hey, this area of bone needs some remodeling. And the osteoclasts come and clean it up, and then the osteoblasts come and build up by replacing the bone. It's very, it's just, it's like a symphony when it's working right. So normal bone is always undergoing this remodeling in a coupled process. Osteoporosis happens when the process becomes uncoupled. It can be due to increased resorption, decreased formation, or a combination of both. And some trabeculae, once they're lost, cause fragility that no matter how much you improve your bone density, it won't help. So that's why we don't want people to get too far along. But we do what we have to, right? Especially when insurance companies don't cooperate. So when you lose trabecula, you lose bone structural integrity no matter what. That's why they now have something called a trabecular bone score. They can go in and measure that and can influence whether your bone density is actually better than it really looks or worse than it really looks. And OSF's had the capability of doing it for a while now, but they're just now letting their techs do it. I don't know why. It took them so long, but as of a month or two ago, they're doing it. So what leads to bone loss? For it's we lose all of our tissues just with age. Some of that's inevitable, especially since we don't ride horses. It turns out that riding a horse is a very jarring event. And if you've done it most of your life, your bone density will be amazing. So if we had not stopped riding horses, we would all have incredible bones. Um, well, of course, we'd also have a lot more sun exposure, so we'd have better vitamin D levels, but we would have more skin cancer if we didn't use sunscreen. Chronic inflammation also is a big factor. It causes immune system imbalances. The key is that you might have not thought about it, but bone marrow is where all of our immune cells come from. That's where blood is made. So that's also where the cells that make bone are made, and they act just like the immune system. So if your immune system is fighting infection all the time, it's going to prioritize that over making bone. Does that make sense? So that's why inflammation causes immune system imbalances. Vitamin D deficiency also is a huge problem. Until we started checking vitamin D levels in the last 10 years, most of us were walking around with vitamin D deficiency, or at least a lot of us were. They even did a study and thought they would be able to see that it was a latitude issue and that most of us in the Midwest were missing vitamin D, but Florida, for instance, would be great. It didn't turn out at all because people just spend much more time indoors in the last 10, 20 years, no matter where they live. So they're not getting vitamin D. Plus, I think there's more pollution. There's all these fires all the time. Those block some of the sun. So that even surfers in Hawaii now, they say aren't peaking at 80 anymore, like was normal. They're peaking around 60 for vitamin D level. Someone told me they thought that was because of sunscreen, but I don't think when you surf all day, your sunscreen really stays on. There's some sunscreen that's good enough for that, but not most of it. But, that could be a factor too. I'm sure it's a factor in the rest of us because some of us use sunscreen every day on our face, and that might be the only thing exposed. So part of this evaluation, we measure everyone's high sensitivity CRP, and our goal is to get it as low as possible, preferably less than 1. And people were able to move that needle quite a bit with some supplements. It was pretty impressive. So these are some visible signs of chronic inflammation and nutrient deficiencies. We're going to review all these in our first group, but I'm just going to go over this first set as an example. So fingernails are a great clue to something being amiss if they have these findings. If they're brittle, like the one on the left here, if they might be kind of hard to see, but they're kind of peeling back. That can be just a general nutrient deficiency, a digestion or malabsorption issue, a need for amino acids, biotin, calcium, zinc, and or other minerals. If you have these vertical ridges or depression, or it's kind of a little bit of both, they kind of go across the nail like that. That's usually anemia from iron deficiency or iron overload or protein deficiency. The white streaks going horizontally on the nail is actually usually zinc deficiency. Chronic soft tissue, that's the one on the far right with the middle finger that looks all red. That's called peronica, and that's also related to zinc if it's a chronic infection. Now, anyone could get that once, in their life. I had it once really bad, and turned out there was a foreign body in mine. A very, very small thorn had gotten under the skin, and I didn't know it till it finally formed an abscess, and we drained it, and out came this thorn. But it looked more like an eyelash. It was that small. But the one, two, three, fourth one, not counting the looking at it as columns. I don't know if you can see, it's got pits in it, like holes. That's from psoriasis and vitamin D deficiency. But I think they have to have psoriasis to get that pitting. So, and so you're going to get a list in this email that looks like this, that you're, and we'll also pass them out the first group visit, and you're going to circle any that you feel you have, and that will give us clues of things that we need to look for. We evaluate fracture risk by looking at your DEXA scan or bone density. The most commonly fractured bones are the vertebra, ribs, forearm, wrists, and hip bones. Standard bone density measures the lumbosacral vertebra because they are attached to ribs, and so they're easier to isolate, and the hip bones. We measure the neck of the hip and the total hip. So that neck that people often go, oh, my neck was low, and they start pointing up here. No, it's the neck of the hip. We never do the neck in the bone density. DEXA scan is very low radiation. It's the amount that you receive is the equivalent that you get if you walk outside during the day. So it's not very much. I don't know if you have to be exposed all day outside, but not much. Here's a list of things. If it's capital MSV, it's millisievert. If it's a squiggly M, it's microsieverts. So the natural daily radiation on the Earth is 2.6 microsieverts, and a DEXA examination exposes you to 1 to 7 of those. The dental X-ray, one dental X-ray is 5 of those. A chest X-ray is 60 of those. So a mammogram is 400 of those, and a mammogram is still considered a low dose thing because it's still in microsieverts. Spine X-rays are a lot of radiation relatively. They're 1.5 millisieverts. So you can add, if you're worried about vertebral fractures, which anyone who's lost more than an inch of height should be. I crossed the threshold and was more than an inch shorter than I used to be. So I did a vertebral fracture assessment, and that's when they use the bone density machine to X-ray your entire spine. And it's much cheaper and uses very little radiation compared to a spine X-ray. So it's a good way to do it. CT scans are high amounts of radiation, but not as bad as being an astronaut on a space station for 6 months. Astronauts also don't have gravity, so they lose a lot of bone. So Dr. McCormick has a whole section on how to detect all these different DEXA scan errors, and I was shocked at how many errors we found. And when I actually put together this talk originally, my analysis of my own bone density has an error in it. I had it backwards, so I fixed it for this talk. And that was a common mistake that almost all the radiologists made. So that's probably why I did it. I was following the way they did it, and it turns out they are all doing it wrong, except for Jessica Gingrich at OSF and another Jessica. There's 2 Jessicas that do it right, and that's about it. So the other issue is some facilities just don't report total hip, and others don't report the neck of the hip. If I can only have one, I want the neck, but I really want both. The Carle facilities often don't report the total hip, but Illinois Cancer Care never reports the neck of the hip, and I don't understand that. I've tried to get it from them, and they don't. Maybe their machine doesn't measure it, but then they need a different machine because that's a key component of the FRAX score. So I don't know why they don't have it. As I said, I was shocked by the number of errors in the first cohort, and probably about 2/3 of them are tech errors to do with positioning and such. But I don't know. Maybe I shouldn't say that. I think there might have been more radiologist errors than tech errors because, like I said, a lot of radiologists were doing that thing I'm going to show you next backwards, like I did. So this is my bone density from 2022. This is before losing 70 pounds. So I was, except for one vertebra, they were all osteopenic. But that L4 is osteoporotic, and it's more than a standard deviation different from L1. So if 2 vertebrae are more than 1 standard deviation different, you're supposed to throw out the high one, not the low one. And almost everyone's throwing out the low one, which makes you look better. So I originally had up here that my L1, L3 should be used, and that made my average minus 1.7, but that was wrong. It should have been, they threw out L1 and did L2 through L4, and then I was minus 2.4, right on the border of osteoporosis. And I said, oh, I'm also noticed when they measure my height with their machine, it said 62 and a half, and I used to be 63 and 3/4, so I'm more than an inch of loss of height. So I would realize I would decide to get a vertebral fracture assessment the next time. I don't show it to you yet, but it was pretty cool. And I was the first adult they ever did one. So nobody seems to know about that. The T-score, so when you do a bone density, you have a T-score and a Z-score. Now, in the last 5 years, I think it's been, but I lose track of time, so maybe it's longer than that. We are trying to not be racist in medicine. It's a work in progress. And one of the problems is I think they don't know how to identify everyone's race. Well, you're supposed to just ask the person who you're testing or examining how they identify their race, and you just take what they say. But nobody was there that day at the politically correct conference, I guess. So uh, they think it's non-racist to remove race. But so now everyone is labeled as white, and I think that's racist too. I don't agree with that at all. I think if you're going to label everyone white, you don't show it. You should block the race label that you've given everybody so that no one sees it if you want to be non-racist. But instead, now it says on everyone's thing. Well, and sometimes it doesn't. Sometimes someone, it'll say black or, and by the way, the only choices are black, white, or Asian. So it's doesn't make a lot of sense. So, but when it comes to bones, it used to be that the T-score, and they claim, I don't know if they claim this was always this way, but they claim that since trying to be non-racist, everyone's compared now to a 30-year-old healthy white female the same height as you, and that the Z-score, I thought at least still compared you to your peers, same age, gender, and race ethnicity. But I think they're comparing everyone to, as I said, to a white woman for that too. Now, I'm going to argue both sides of this. For one thing, if you, I have to put everyone into Asian, white, or black. White would be in the middle of those. Asians have lower bone density than whites, and blacks have higher bone density than everybody else. So if everyone uses white, maybe that's a way of averaging everybody. But again, if you're going to do that, just take race out of it or block race so that nobody sees it. Because someone who's Asian or black gets the report and sees under race white, they're very, very offended. But sorry, that's my soapbox on that one. And I actually tried to have this talk with the people at OSF, the techs, and they did not get it. They kept saying, no, it's non-racist, non-racist. No, just because they tell you it's non-racist doesn't mean you don't have to use your head. Think about it. How would you feel if you got your report and it said you were black or Asian? Would that bother you that they've mislabeled you? I think it would. So anyway, because obviously the two techs were both white, so they didn't get it. So anyway, standard deviation is a measurement of the variation of the bone density around this bell curve. And the top of the bell curve, T0, is this average 30-year-old. And we're trying to figure out what you have lost since then. So normal is to lose up to 1 standard deviation from that. So normal is -1 and above. Osteopenia is -1 to -2.4. Osteoporosis is 2.5 standard deviations or worse. If you have osteoporosis and you've had a fragility fracture, it's considered severe osteoporosis, or if it's -3.5 or lower, it's severe no matter what. Okay? For every doubling for every additional standard deviation, the risk of fracture doubles. So if you go from 2 to 3, it doesn't go from 2 to 3, it goes from twice the risk to 4 times the risk. You go from 3 to 4, it goes from 4 times the risk to 8 times the risk. So as those numbers are getting smaller, your risk is going up exponentially. But that also means that even though, so I was wrong and my bone density was really a minus 2.4, it was really the same as a minus 2.6. There's no difference really. So, once you're in that minus 2.3, 4 category, you might as well be called osteoporosis. That doesn't mean that you should start taking medication. But Big Pharma jumped on that and said, oh, so everyone then should start on medication at minus 2. The bad thing about that is they don't offer you the good medication. They want you to go on a bisphosphonate first. If you go on a bisphosphonate first, bisphosphonates stay in the bone for years and years and years. So if the bisphosphonate doesn't work, now when you want to go on a better medication, that bisphosphonate still lives in your bone and it won't work as well. So my whole thing is don't go on a bisphosphonate early. I did put people on Prolia early because we thought it was different than bisphosphonates, and well, that turned out to be wrong. So now it's don't go on anything early. Wait till you're in that -3 to -3.5, or you just shouldn't even really go by these T-scores. You should go by your FRAX score, because your FRAX score accounts for risk factors. Like, do you smoke? Do you drink? That raises it a lot. Did your family member have osteoporosis and break a hip? That raises it a lot. Have you already had a fragility fracture? And some say it has to be fragility fracture after or around menopause. I mean, I had a fragility fracture the year before I went through menopause. I think that should count. So, and we'll calculate everyone's FRAX score. Trust me. So this was what I was talking about, that you could get the vertebral fracture assessment along with your bone density. Hopefully the more we do it, they'll get better at it, because it took them quite a bit to do it on me because they couldn't figure it out. And I think they had to do it 3 or 4 times. So it was still not even close to spine x-ray radiation, but I'm glad that they used me as their guinea pig. I'm okay with that. Anyone who's got like any upper kyphosis, which I have some, and it turned out I don't have a fracture yet, but I am still pretty rounded without it. So that's why I've been wearing this thing to improve my posture, and it worked great. And my posture was like 100% for a couple months in a row. And I thought maybe I don't need to wear it anymore. And just a month of not wearing it, I was back to slouching as bad as when I started. So I guess I'm going to wear a magnet around my neck for life, well, at least a lot longer than a couple months. So we also are going to talk about primary, or you could call that age-related osteoporosis versus secondary osteoporosis. And the vast majority of us, even if we have risk factors, are going to be age-related osteoporosis, because you have to be more than 2 standard deviations different than your peers to be secondary osteoporosis. But that doesn't mean you shouldn't be worked up for it. I work up everyone if they're more than 1 standard deviation different than their peers for secondary osteoporosis. That's how I was taught. So if you're purely age-related, you don't have any other disease processes contributing to your bone loss. And then they even have types for whether you became osteoporotic around menopause or later, but it doesn't matter. It's all the same codes from the ICD-10. It's age-related. Risk factors are, sorry, I experimented with having Perplexity Pro. I think I had to do it, or it might have been ChatGPT. I'm pretty sure it was Perplexity. I asked it to make my slides more concise and take what I used to have on the slide and make it the notes. And it did it like in a few minutes, and I was so impressed until I opened it up and it didn't put what was on the slide originally as notes. So I had to take an old version and do all that manually. So my husband thought I was going to be so impressed with it, and it didn't work. But maybe it's just because I didn't use the right AI or I don't know. But anyway, you keep saying I'm going to learn it's going to make my job easier, and I'm trying it. We'll see. So it thought that making it more concise would be changing disorders to dirters. So these are risk factors. Chronic depression itself is a risk factor. And you'll see under medications, taking antidepressants is a risk factor. I'd rather take the medications then and not be depressed than be depressed and lose bone. But we can try to take the least amount and do other things, so don't worry. Family history of a first-degree relative with osteoporosis. That I have in spades, and most of you probably do too. In men or women, delayed puberty is, and delayed puberty is anytime past 12 to 13, I believe. So I started at 14, not much past, and then I went through menopause early. And the later you start, the more likely you are to stop early, I found out. So one of our participants told me she started at 16 and was done at 38. So the later you start, the less chance you're going to have a baby, just so you know. So if you're, well, most of you are past that age, but if you have a child who did that, you might want to warn them, because nowadays a lot of us are having babies in late 30s because that's when you finally get to it if you put career first. So low body weight, less than 127 pounds. If either parent, this is maternal history, but either parent had hip fracture, you're from fragility at old age, then you're at higher risk. If your parent was in a car accident and got a hip fracture, you're not. Or like one person had answered yes to that, but then later told me, oh, well, it happened in a construction accident. Yeah, that doesn't count. It's having one at old age just from falling and stuff. So poor health in general is a risk. Chronic disease of the kidneys, chronic GI disease or lung disease is a risk because a lot of those are treated with steroids. Sedentary lifestyle is less than 90 minutes activity a week. Smoking, alcohol, 3 drinks or more a day, and poor nutrition. Secondary basically just means there's other things that are contributing to your osteoporosis. And it turns out menopause before 40 is also considered secondary osteoporosis by the FRAX score model. So like for my instance, even though I'm just in the -2s, I have a high FRAX score because of the premature menopause. So secondary osteoporosis causes, I just listed a lot of the diseases. I said GI, lung, and but now I'm listing them in even more detail. Adrenal gland insufficiency is when your adrenals can't make cortisol for you so you have to take it. But when you have to take it, it's never the same, and so it does wear the bones more than if you just made it yourself. Ankylosing spondylitis, I assume, because they take a lot of steroids too. Autoimmune diseases, cancer, celiac disease is a big one though. Crohn's disease, Cushing's, again, because of steroids, cystic fibrosis, a lot of steroids, diabetes, so is a risk, both kinds, hyperparathyroidism, hyperthyroidism, inflammatory bowel disease, lung disease, multiple sclerosis, osteogenesis imperfecta. Those are those kids that fracture. They have it really bad. Parkinson's disease, primary biliary cirrhosis. It's funny, they don't list premature menopause anywhere in here, even though it is in the FRAX score model. Medications, it's glucocorticoids, glucocorticoids, glucocorticoids. And that could even be steroid shots if you're getting them if you're getting 3 or 4 a year, it's gonna lower your bone density. Anti-seizure drugs. So I took phenytoin and phenobarbital growing up. I had epilepsy, so I was on those for the first 13 years of my life. So I'm sure my peak bone density wasn't very good. And I come from a family of people with bad bone density. So, and then I thought I was doing a good thing running 26 miles. So, other meds are lithium carbonate, not lithium orotate. Lithium carbonate is for bipolar. It's given like 300 milligrams, one or two of those 3 times a day. It's very high dose. Cytotoxic chemotherapy, Depo-Provera birth control. So that's a big problem, unless you have a great bone density to start with. And, some girls do, if they're active and whatnot, then I think they're fine. Heparin long-term, the thiazolid, TZDs, we called them. They were diabetic meds. And there was two that were used for some period of time, Avandia and Actos. Actos is the only one left, and it's pioglitazone, its generic name. But we do still use it. I use it more for helping people lower their leptin levels in mold exposure but sometimes I've used it still with diabetics when I'm desperately trying to give them something that's not insulin. I'll give them anything to avoid insulin. Proton pump inhibitors, selective serotonin reuptake inhibitors, and opioids. I didn't know that about opioids. So a lot of my patients who've been on opioids like 5, 10 years probably should be getting bone densities. Beyond quantity, what about quality? Well, bone density only tells us about quantity. Also as important is how likely are you to fall. I'm a klutz. But I found out that at times I've been more of a klutz because my DHEA was super low. And when your DHEA is low in women, less than 60 is what they say, but I found it was more like 30s and 20s, that you definitely will develop muscular weakness and poor balance. I was trying to lift 5-pound dumbbells and I was having muscle fasciculations, and they didn't feel heavy to me even at the time. And I was like, what's going on? And I happened to have labs the next week, and my DHEA was like, I think it was in the 20s or something. And so I started taking DHEA, and in a week I could already lift 10-pound dumbbells without that. So, I mean, it was ridiculous. So it really is real. And it doesn't have to be just people over 60. That's who they say this happens to, but it happened to me. So we want to like approach and have a more balanced approach, not like us who have done endurance athletes. We want to have a balanced approach, and a balanced approach maintains strength, balance, flexibility, and coordination. And so there's all kinds of activities that are good for that. And just because your bone density is better doesn't guarantee it's good quality. Although some people, I was talking to Dr. McCormick about a person who'd been on Prolia 10 years, and he's like, well, I'm sure her bone density is not good quality, though. No, it was good quality. So he was wrong, but can't know everything. So when it comes to this slide was originally about bisphosphonates. And so that first line, that you shouldn't take them for more than 3 to 4 years, is for bisphosphonates, which is like Alendronate, Fosamax. There's a bunch of them. Boniva, I can't remember what its generic name is. And I tried all of those, but it was all before I had the hiatal hernia surgery, and they all made my heartburn much worse. So I couldn't tolerate them before that. And now that I've had that, I'm not allowed to have those. So those are off the table for me. Turns out, like I said, we thought that this was an issue with just bisphosphonates, that you need a drug holiday, but it turns out it is an issue with Prolia as well. And we also didn't realize when we started all these people on Prolia, to avoid bisphosphonates, that they would have to at least do 1 dose of a bisphosphonate IV when they go off of it to keep it from rebound loss. But that's the problem when outcomes that are 5 or 10 years out are never known before a drug goes to the widespread market. They can't, if they had to do a 10-year study before it got to market, then the drug would be like instead of being a $2 million process, it'd be a $10 million process. So you can imagine what the drug would cost. So bone resorption markers, those are, I used to want to get them, and I'm not saying insurance reimbursement for them is great, but it's good enough. So now most of the time they're covered, at least some of it. They don't cover it well enough that I'm going to take on the billing of it, but they're covered well enough that you shouldn't have to pay much. Um, so, and they're very helpful because a bone turnover marker tells you today what is your bone doing this minute, and you need to know that because it fluctuates day to day depending on what your diet is like. And so, if you, some people have high turnover where the bone markers for both the builders and the chewers will be above what we want. And so clearly those people are at higher risk for osteoporosis because they're chewing and building up a lot of bone. But you also have people who are on the other end who they've been on meds too long and now they're not remodeling at all and they're at risk for atypical fractures. So that's the people who need to go on a holiday. And it's nice to have these markers before people go on so we know where they're starting from because and if their bone markers are really good at baseline, maybe they don't even need medication. They just need to if they're good because they're weightlifting or something, they could just keep weightlifting. But we'll see. Um, Dr. McCormick preferred CTX. He said it was the most accurate, and his reference interval for it was that the goal for postmenopausal women and men over 50 was to be 100 to 375. He said some people might still lose bone in the 300s, and some people can be 400 and not lose bone, but you have to pick a cutoff somewhere. So that's why it's 375. Then for the bone formation markers, his favorite was the P1NP. Um, and if that's low or high, it's a problem, like I said, because if it's low, that's bone that's frozen, you're not making any, you need a holiday. But if it's high, it means you're turning over bone because you're pulling minerals from it. If you're coming off a Prolia and your P1P is 90 or higher, it usually means you're about to fracture a vertebra. Although, as far as we know, somebody who was 90 for a while didn't fracture, and it did finally drop. So it just seemed like it took forever for the reclass to show the drop, but it did. So he wrote two books. The one was written maybe 10 years ago, and it was the whole body approach to osteoporosis. But I think his style was awesome. I liked the way he set up these sheets called therapeutic targets that really makes it so that if you have these sheets filled out, you know what you need to do to improve your bones. So that we're using that from that book. And but like for instance, what he was when he wrote that book, the boneheads were still saying take 1,500 milligrams of calcium with 800 IUs of vitamin D, and that approach, if you did it for 10 years, your coronary artery calcium score now will be very high and you're at risk of heart attack or stroke. So we can do things to reverse that, so don't panic. But the, so I always tell people, if you don't like what I'm saying, just come back in a year, it'll change. And that is it's always been true, especially when it comes to anything nutritional. Nutrition is always evolving and it's always also kind of on a pendulum, low carb good, low carb bad, low carb good for some people, not for everybody. Maybe, but it's better for more people than we thought. Um, and there's different ways to do low carb too. Like the low carb approach for Alzheimer's emphasizes a lot of fat, not a lot of meat. So it's like 75% of your calories come from olive oil. 75%. Yeah. Pretty crazy. I was able to do it, but I then realized that I needed to be alkaline for my bones, and ketoacidosis says it in the name. You can't be in ketoacidosis and be alkaline. So I had to add carbs back to not be acidotic, and we'll see how that goes. So most people are going to need to take 600 to 700 milligrams of calcium a day, and they have to, if they drink calcium fortified orange juice, you got to count that calcium in your total, or just skip it. I like the calcium mango. I don't like the calcium fortified orange juice. It tastes chalky. I like the mango orange juice, is what I was going to say. But oh, and citrus, you think it's acidic, right? Because it has that acidic like taste. It's alkalinic. It makes your urine more alkaline. Learn something new every day, a couple times a day. Vitamin D3 and vitamin K2, a marriage made in heaven. But it turns out we can make this marriage better if we make it a foursome. We want K2 in two forms and K1. So D3 increases calcium absorption in the gut, and it's more bioavailable than D2. The prescription vitamin D2, 50,000 units, will not get you to a good level doing it once weekly. You have to do it every 4 to 5 days to get above 30 in most people. And it's not as bioavailable, so I'm not a fan of it. But if that's the only way someone can afford vitamin D, I will write them that prescription and write it for how often they have to do it. But they've also shown that daily D is better than weekly. Now, we have some people who are going to do every other day, and I think that's still better than weekly because it's the frequency helps. Vitamin K2 also is better daily, or at least every other day, because the MK7 K2 does have a long enough half-life that if you're doing that one, you could do it every other day. But K1 and MK4 K2 have to be done daily. So vitamin D sends or makes calcium get absorbed. K's send calcium to bones because they activate osteocalcin. And magnesium activates vitamin D to its active form. So magnesium is also important. So that's why I said it's really a foursome. It becomes vitamin D3, K2, calcium, and magnesium. I first said it was because of all those Ks, but even if we simplify it and make the Ks, we need calcium and magnesium too. And remember, bone cells are derived from the same precursors as our immune system, and vitamin D controls both that immune system and our bone health. So when vitamin D keeps our immune system from overreacting when it gets to about a level of about 40. Now, this is the caveat for you. They figured out that most of the time when people are above 40, their immune system doesn't overreact. And we know this because of trials that were done on influenza and COVID-19 that showed that people across the board, everyone who got hospitalized had a vitamin D level in the teens. So when your vitamin D level is in the teens, your immune system is out of control. If it's in the 20s, maybe you're pretty ill at home, but you're not getting hospitalized. 30 is even better. Okay. Now, the reason that we like 40 is because we found that low dose immunotherapy works much better in most people if their vitamin D level is 40 or higher. But you have some people, they also found though it would work in people taking 10,000 units a day no matter what their level was. Well, would be because maybe that amount of vitamin D is enough to suppress the immune system, because the level, if you haven't been on vitamin D forever, it might not budge because the priority is the activated form. So those people, if you check, they have a parathyroid issue already started from long-term vitamin D deficiency or calcium deficiency. Either one shoves the parathyroid hormone switch into on, and it gets stuck on. And when it's stuck on, then all the vitamin D is rapidly always converted to the active form. And so no matter you're taking all this vitamin D and it just seems to be disappearing, or you assume you don't absorb it. So you keep taking more and more and more. And I did this before I knew this. I had to take 20,000 of vitamin D before I could get in order to get my D just over 50. And I was trying to go, I wanted to see what it was like to have between 50 and 150. Well, about the time that I was getting close to that, the lab changed and no longer reports anything over 120. So I wasn't going to be able to see what it was like at 150. So once I got over 120, I started backing off and backing off and backing off. And now it's hard to get it down. For one thing, it's fat soluble, so I probably stored a lot of it. Vitamin K is also fat soluble, but we don't store it. But after doing this osteoporosis group, I learned that I really want mine to be like 40 to 50, or right at 50 would be fine, I think. I hope I don't have to like try to keep it like right at 40 to 45, because then it'd be so easy to dip too low, and then I don't want my LDI to not work, because it's wonderful. So um, you can also get 100 micrograms, I believe, of mostly K1 in 5 to 6 prunes a day. And even though that's not a lot of K1, that was done in a study and shown to improve bone density in women over 2 years. And prunes also would help offset the constipation of calcium. Magnesium, can have the opposite effect and can also offset that. And you need magnesium to activate your vitamin D. And if you're hypomagnesiemic, you also will not be able to get your calcium up. And it'll look like you have hypoparathyroidism, but it's due to your low magnesium. This stuff is really fascinating, but really complicated. So we came up with some basics that we were going to do on everybody. I probably would say that I've added a lot more of them to that, because I actually ended up doing parathyroid panel on almost everyone, because in the last few years, we had drastically reduced people's calcium, many to none. And that's not good either. So uh, turned out the only way to really know how much calcium can this person take is to do a parathyroid panel and see the state of their parathyroid gland. And then you can figure out how you want to handle their calcium. I think almost all of the people who are hyperparathyroid and their calcium is still, though, within normal limits, not above 10.3, are probably still reversible. And we reverse them by slowly increasing their calcium intake. Because you can't do it fast, because they're primed to be high calcium. So if you gave them all the calcium they need, they would now have hypercalcemia and might have a seizure or something, tetany, where cheeks would, there's these signs of the cheeks. But you can start with, like, we're using Bone Restore. They can just do 1 for a month, and then they can do 2 for a month, and then we can recheck and see. And if their parathyroid is improving, we're doing the right thing. So these are other labs to consider. We look at all kinds of clues. Like I said, the DHEA is important because it's really low. It's causing muscle weakness and falling. The calcium phosphorus ratio is considered a good clue. If it's 3.5 or higher, they're hyperparathyroid. If it's 2.3 or lower, they're hypoparathyroid. Growth hormone's important if you're wanting to take one of the anabolic meds, 2 of the anabolic meds, Forteo and Tymlos. I asked the Avidity medical liaison if it affects their stuff, and they were supposed to send me articles proving it didn't, and I don't think I ever received them. So I don't know if Avidity. I'm hoping Avidity's that growth hormone doesn't matter, but if it, I need to go back to them and make sure that they sent me what they said they were, and figure out if it does or doesn't. Or I can just ask Perplexity, because half the time it finds all that stuff pretty fast. Here's more labs. A lot of the labs that we do on everybody, we don't have to do all of them. That's why we are looking at the signs and symptoms of nutrient deficiencies, because then that will point towards labs that we need to do, so that you don't just, run up a huge lab bill. So I always say that when all your hormones are happy, everything works better. So, and vitamin D is actually a hormone. It's really a hormone and a lot more. So it increases calcium absorption in the gut. It regulates our T cell production, and it promotes T reg cell production. And because of doing these 2 things, I got to talking and not looking at my notes. Oh, well, I didn't have notes on this page. Anyway, because of doing those 2 things, it's why it's required for low dose immunotherapy, because those are the cells involved in autoimmune and disease and allergies. So it also lowers the pro-inflammatory cytokines such as IL-17. It stimulates antimicrobial peptide production from white blood cells. Vitamin D is necessary to maintain a healthy gut microbiome. That's huge. And it modulates, as we already said, it modulates the immune system and is anti-inflammatory. But the right amount is important. Too much is just as bad a thing as too little, which was a shock to me. It really was. So I'm recommending you get these. You'll get these strips. You can get ones for a little more money that also measure your calcium, and if you're really worried about it, you can certainly do that. But this is the way that McCormick does it. He just has people check their first morning urine pH for 7 consecutive days and average it, and he says the goal is to be above 6.6. That's not true if you're a stone former, just so you know. Stone formers, I've figured out their optimal pH is 6.1, based on a gentleman who has the capability of making 3 different kinds of stones. A lot of people are capable of making 2 different stones, and for one, you want to be 4. You don't want to ever be 4 to 6, and for the other one, you never want to be 6.3 or higher. So people who make those 2 kinds of stones can be between 6.0 and 6.3. But this gentleman also makes brushite stones, and for those ones, he has to aim for just 6.0 to 6.1. I don't know, 6.1 to 6.2. Yeah. So I hope I don't meet anyone who makes 4 kinds of stones, but it could be out there, because the only kind he didn't make was the urate. So there might be someone out there who makes the same 3 he does and urate, and then maybe there's no such pH for that person. I don't know. So most of us are going to be trying to shift our pH up, but not the stone people. You are wanting to be between the 6 and 6.25, okay? I'm going to have to come up with a different protocol for them, because my protocol is for reducing hypercalciuria, and it's assuming that those people don't form stones, I guess. Or maybe the other thing, though, this guy who had all these precipitates, he only had taken in one urine test 1,400, another urine test 1,200 cc's. And first rule of avoiding stones, 2,000 liters a day at least intake. So that's the most important thing. So that's if you make stones, your first order of business is to take in 2,000 liters a day, and then we'll go from there. Dilution is the solution. Supplements to promote alkalinity. Well, there's a whole bunch of them, and we have a protocol for it, but these are some of them. Oh, but the bummer is that supersaturation profile I was talking about, OSF discontinued the test on June 19th. I hope that it's a temporary discontinuing, but we don't know. It's not available on their panel anymore. So and it's a Mayo test. So we might have to find out if it's something Health Lab could send to Mayo, then we could still do it. That's a great idea. I didn't think of that earlier. Have to ask our rep. Maybe Mayo discontinued it, though. Then we're still back to square one. I'm wondering if it looks like a test that would use a ton of reagents, and maybe they're having trouble like everybody else getting the right reagents. So I kind of have a feeling that's the problem. So there's actually probiotics that can improve skeletal health, and a couple of those are listed here: Lactobacilli reuteri and Rhamnosus. And those two, I'm not 100% sure about reuteri. I know for sure that Rhamnosus is a low histamine one too. And then Faecalbacterium and butyric acid also increase bone formation. I don't know where they are at histamine-wise, by lowering osteoclast formation. But very interesting. All of our medications are pretty much in 2 categories: anti-resorption and anabolic. Anti-resorption is they reduce bone loss. Anabolic, they actually build bone. Evenity is a new one that does both of these. hopefully that means it's all good things and doesn't have all the bad things of both. Well, I shouldn't say, nothing is ever like that. But anyway, so the bisphosphonates are alendronate, risedronate, and zoledronate are the ones we use typically now. Um, only zoledronate, I believe, is available IV, but I could be wrong. Prolia is denosumab. It's a biologic that binds and sequesters osteoclasts. Calcitonin is rarely used anymore, and it only affected the spine, but it does supposedly reduce vertebral fracture pain tremendously, so it's been used anecdotally for that. Estrogen progesterone does reduce hip fractures, according to the Women's Health Initiative, and it was statistically significant. Does anyone know that? No, because they did such a terrible job of talking about the results of their study. Oh. SERM, selective estrogen receptor modulator, like raloxifene, also improves bone density. And there's something new called a tissue-specific estrogen complex that uses estrogen with a SERM. Very interesting. Then on the bone building side, we have Forteo and Tymlos. Those are both parathyroid analogs. So, like I said, parathyroid is important for bones. Hyperparathyroidism causes a bone loss. Hypoparathyroidism would also cause issues. But turns out a little shot of parathyroid every day stimulates bone building. But I don't think you could use that in people who have parathyroid issues, obviously. Maybe in the low ones, but not in the high ones, probably. Evenity, although I do have a patient who's on Tymlos, and then her renal doctor decided to measure her parathyroid after starting her on it, and I have no idea. Well, I think her parathyroid hormone is excessively high, but we're increasing her calcium slowly so that we can bring that down. But and they, I think they felt that it was something that should be obvious, but it was not to me. I think now in retrospect, maybe does hyperparathyroidism have something to do with diabetic renal disease? Maybe. Because if you're diabetic and you have some renal insufficiency, then your kidneys are the ones who activate the vitamin D. And so maybe that is where it goes awry. But I don't know anywhere if it says that therefore diabetics are all hyperparathyroid. I don't know. So, oh, the issue is if your bone density lands you in the you need to treat it category, but it's not really bad, they want to put you on those on the left. And like I said, the ones on the left, if they don't work for you, will make the ones on the right also not work as well. So we're all better off starting on the ones on the right. So this is one time where ignoring advice might be better, but it has risk. So Dr. McCormick, even though he's a chiropractor, is an advocate for medication use, but he has pointed out that working on your diet first, you'll get better results. There's a smarter order to the medications that no one else seems to want to do, but if you really fight for it, you can do it. Now, I bet you at 40 years of age, a man, there is no, the Medicare or insurance formula for men in osteoporosis in this country is 100% broken. I have men with hip fractures who I can't get bone densities on. Something has gone wrong with the formula in the last 3 or 4 years. And when the hospital puts that man in their formula, everything says his bone density will not be covered no matter what diagnosis code they use, no matter what we put in. And so our workaround is we found that Fort Jesse in Bloomington will let them do it for $125 cash self-pay. And we can also do that if you want a bone density sooner than what your insurance will let you do. But I would bet you that McCormick, when he started fracturing at 40, there's no way anyone would pay for his bone density. So he probably has been paying out of pocket for doing all this. So And I bet you when he went on, I think he went on Forteo. That's all there was back then. I bet you he had to pay the $1,000 for it monthly. I bet you, but he was willing to do it. It was worth it to him. But not everybody has $1,000, so some of us have to fight with insurance. Um, but even if you've already done medications, there's still plenty of stuff we can do. So don't freak out. And again, like just some small changes, we were improving people's like hypercalciuria and already seeing improvement. So that's huge. Like I said, these are our group visits. We already kind of looked at this list. Um, and then I just kind of wanted to summarize this for you. Basically, this is what it all boils down to, right? You ever heard that phrase? Here's your bones, and your bones are your bank of minerals. That's where we store all our minerals, mostly, that we need. And so when we need minerals for anything, we go to the bank and we withdraw minerals. And so, again, calcium, vitamin D, vitamin K, magnesium, but even other minerals are important. By the way, I went to the osteoporosis clinic to see for myself because I know the Carl Osteoporosis Clinic told one of my patients that she couldn't take boron and zinc and selenium. And I was like, I'm pretty sure they're confusing it with strontium because I can understand why they would not want anyone to take strontium, and I'll explain that later. But no, they told me the same thing at the OSF Osteoporosis Clinic. Oh, you're taking something with boron? I don't think you're supposed to do that. People, our bones are made up of more minerals than just calcium and magnesium. So they benefit also from these micro minerals. And where they got this idea that people shouldn't be taking any minerals, wow, that's bad. I mean, it's one thing if you want me to hold it for a week before my bone density. I don't think I don't think it's going to make a hill of beans difference, but that's what you're saying. I can do that. But I do not think that anyone should be avoiding minerals. That's crazy talk. If your diet is acidic, if you're running on the acidic side, your bones then donate calcium to buffer the acidity. And some people also just excrete too much calcium in their urine. And we want our calcium and our minerals going into our bones, not our urine. And so that's why the 3 kinds of K and um, and magnesium to activate the D and calcium and other minerals are important. But nothing promotes bone remodeling like exercise, especially weight bearing and weight resistance. So that's another key component. I saw big changes in my bone density when I was doing weightlifting regularly compared to when I wasn't. Medications can be helpful and they can be used for shorter periods of time if you fix some of these issues first. They don't routinely test for hypercalciuria at either osteoporosis clinic. And one of my patients who turned out to have hypercalciuria because I tested her then for it, did a year of Evenity and it didn't work because she was excreting all her calcium in her urine. If you're putting all your calcium in your urine, it doesn't matter what you take, it's not going to go to bones. So I'm sad to report that I don't think the osteoporosis clinics know what they're doing, but that's between you and me. Don't go on record quoting me, please. Uh, they're nice people and they mean well. It's not them. It's not the nurse practitioners. Somebody in the radiology department is telling them that women can't take these minerals. So I don't know what it's based on, but it's not good advice. So our first group met on second Tuesday and the fourth Tuesday of the month, and I think about half of them want to keep doing it. So we're going to keep those groups going. And I thought, well, if we need to we'll add all of you in that want to do it. And if we need another Tuesday, we'll do it the third Tuesday at noon. But if we have a bunch of you who want it after work, just speak up, and then maybe we'll do a slot of that too. I need at least 6 people to be in a slot to make it worth doing. I mean, I like 6 people because if even 2 people drop out, it's still worth doing for 4, but I want to start with at least 6. And can also be attended virtually for those at Snowbird, or if you live quite a distance away. I want as many people to attend in person as can because it makes it more fun, but I don't want people who can't attend unless they do it virtually to not attend. So if you have to attend all of virtually, that's okay. I even said introverts, if it's easier for you to have a good experience by attending virtually, then go for it. I want everyone to be comfortable. And um, so, you know, I'm sending out a poll with this for what slots you would prefer. And we're not doing a kickoff meeting in person. This is to take the place of that because I was so caught up in the Cubs that I lost track of time, and we don't have time to get together in person. So this is how we're going to try to still get started on time in September. I'm so sorry. And the other thing is, if by some chance the Cubs end up in the postseason, I will lose my mind and we'll have to go an extra month because October will be canceled. I mean, I'll have to still earn a living, but we'll see. Oh, goodness. I'm sure I'm getting ahead of myself because we're still many games back, but we did get some of them back from the Brewers. Woohoo! Okay. Have I said everything I need to say? Yes, I think so. So your objective is to answer the poll. Let me know that you're coming. Oh. And it used to be that I could set up the poll so that everyone who answered it showed me the email that answered, and only I saw it. So it still kept it all anonymous to the other participants. And it's still no, you guys can't see anyone else's answers. And but they removed that. So I'm adding a question where you have to tell me who you are. And it's because otherwise I can't put you in a group. Oh, it's so silly. I don't know why they have to, everything changes so fast. I mean, that's why they're computers, they change all the time. But when they change the functionality so often, it makes it hard to keep up. Before it was easy. I clicked a button and it said participants' information will be collected, but only you will see it. Perfect. That button no longer exists. Okay, so pray that this recorded and I will be able to email it to all of you today.